So we are going to start first kind of with chapter 2, brief overview of the human body. Before I get into this, I will say, if you are a hand writer of notes, I would recommend typing, okay? This is gonna be a lot of information, it's gonna go very fast, you're not gonna be able to keep up writing, okay? If you're not used to recording lectures, I would recommend recording the lectures, okay? A lot of what we say is not gonna be on the PowerPoints. Everything that we say is fair game for testing quizzes, okay? So make sure you're getting all of the content in whatever way works best for you, okay? All right, so starting first with the organization of the human body. Hopefully this looks familiar. Hopefully some of this will be a brief review from your previous anatomy or physiology classes. But if you look at this pyramid, at the very bottom, we have chemicals. Okay, so think more like your atoms, your molecules, everything that creates the basic foundation, the building blocks of all matter. Okay, so these are going to be things like oxygen or protein. Okay, next up from that we have cells. These are going to be the smallest living units in the body. Okay, so again, the structural and functional units of all living organisms. Groups of these cells then make up the tissues. Okay, and then your tissues are going to make up all the organs, the structures, and all the other content of our bodies. Okay, so the human body has 4 types of tissues. What are they? Cardiac, muscle. We have muscle.
Skeletal, nervous.
Muscle.
Nervous. I think I heard epithelial. Connective. All right, so again, 4 types of tissues. We have nervous tissue, we have muscle tissue, connective tissue, and epithelial tissue. Okay? So all of these are arranged and they work together in order to perform specific functions. Okay? And these are basically known as your organs. So your organs are groups of organs that contribute to specific functions within the body. Okay? So we have 11 distinct organ systems in the body. Okay, so what are your organ systems? I heard endocrine.
Endocrine, digestive, respiratory,
Respiratory,
mental,
lymphatic, urinary, reproductive, muscular,
muscular, skeletal,
nervous. Okay, it's hard to keep up with all those. So, our organ systems, we have skeletal, muscular, nervous, cardiovascular, respiratory, digestive, lymphatic, integumentary, urinary, reproductive, and the endocrine system. Okay, so make sure you know those. So these systems are basically what's creating your structure for this entire class. So each unit, we are going to go through these systems one by one and kind of dissect them and look at the different pathologies associated with them. Okay? So then at the very peak of our pyramid, we have organisms. Okay? So which for us, that's going to be the whole human body. Okay? So here is a list of all of your different systems and then the component organs that work to create those systems. So again, we're not going to read through all of these now, but as we go through the semester, this can be a good reference slide for you to make sure you understand kind of what belongs in what system. All right, so we're going to start first with chapter 2. This one we're really not going to dive very deep into. We're basically just going to talk about risk factors and then move on to chapter 3. Okay, so chapter 2 is all about mechanisms of disease. So your important takeaway from this is to understand the predisposing risk factors for disease that basically determine an individual's susceptibility to pathogenic conditions. Okay, so when I talk about predisposing risk factors, okay, or predisposing factors, these are your risk factors. Okay, so those terms are basically synonymous. These make people more vulnerable to disease. Okay, but they do not necessarily predict the development of the disease. Okay, so it's just an association at this point. Okay, and on the other end of this, the absence of any predisposing risk factors does not necessarily guarantee that an individual will remain disease-free. Okay, so So a good example of that is lung cancer, right? We know that smoking is associated with lung cancer, but there are people that get lung cancer that have never smoked in their lives. So that would kind of be an example of the statements that I just said. Okay, so here's a list of your main risk factors that are going to be associated with the majority of your conditions or pathologies. Okay, so we have age, gender, environment, heredity, lifestyle, physical activity, and socioeconomic status. Okay, so different aspects of these risk factors can affect the development of diseases, okay, or an individual's susceptibility to certain conditions. Okay, so if you look at gender, for example, there are so many conditions where women are much more at risk than men. Okay, you think about things like MS, osteoporosis, breast cancer, women are going to be much more at risk than men. Okay, so every condition is going to have a breakdown of the predisposing risk factors and what aspects of these different things are associated with an increased risk for that specific pathology. Okay, so for now, we're not going to talk in depth about each one of these. I just want you to know the big overarching categories that will lead you in that direction. Okay, so in addition to your risk factors, there is a ton of other factors that can also be related to mechanisms of disease. Okay, so if there's any previous history of cancer, genetic diseases, immune disorders, infections, inflammation, obesity, any previous physical trauma, domestic violence, cultural diversity, psychological conditions. All of these things are items that you have to consider when looking at the risk factors for a specific pathology. Okay, and that's the highlight reel for chapter 2. Okay, risk factors, predisposing factors, understand what that means as related to different pathologies or conditions, and then your big categories that we would want to consider with each individual condition. Okay, now chapter 3, this is focused more on cell injury and cell death, and this is where we're really going to start getting a little bit more in depth with your materials today. Okay, so first, just looking at our big picture overarching concepts for this unit. This is going to be more your outline kind of for this entire chapter. So most important thing here to understand is that body cells can change in order to survive and to maintain their functions, okay? When any type of stress occurs that can be harmful, your body cells can change, okay? Cell injury and cell death then occur when that stress becomes overwhelming. So when it becomes too much, the cell can no longer handle it, that's when you're gonna get cell injury, that's when you're gonna get cell death, okay? Or if your cell adaptation is ineffective. Okay, and then lastly here, there are several different types of mechanisms that ultimately can lead to this cell injury or cell death. Okay, so these are the things that we're going to kind of talk through this morning. So when we think about cellular change, okay, cellular adaptations, all right, they are able to react to altered body conditions. So they do this by adapting either their differentiation or their growth. Okay? So these alterations could be either really minor changes in order to adapt, or they could be really major changes. Okay? If we think about what a minor change might look like, this is usually something that is reversible once a stimulus is removed. Okay? So on the other end of that, if you're considering what a major change would look like, this is when the actual structure and the function of the cell is permanently changed. So this is no longer reversible. Okay? So this means that the actual DNA in the cells may be significantly or irreversibly altered. Okay, that's going to be your major changes. And that alone can result in the development of disease. Okay, so the goal is to identify these things early enough where you're not getting that permanent change in the cellular structure or function. Okay, But overall, cellular adaptation mostly is a good thing because it allows your body to react to circumstances and then adapt in order to protect themselves, okay? But just understand that if you have an adapted cell, this is not the same as a normal cell, nor is it the same as an injured cell, okay? It's just different, okay? So there are several different types of adaptive responses for these cells, okay? So here's a list of these. We're gonna go through these individually, okay, to make sure you truly understand what each one of these adaptations is. So the photo is a good visual representation if you're a visual learner, okay? So at the top of that image, you have normal cells. That's what they should look like, okay? On the second line, we have atrophy, okay? So atrophy is gonna be when there is a decrease in the size of the cell, okay? Versus hypertrophy, there's going to be an increase in the size of the cell, okay? We also have dysplasia, and dysplasia is when the cells have an abnormal size, shape, and relationship to the other cells, okay? Hyperplasia, there's going to be an increase in the number of cells. Metaplasia, the actual cell type is going to be changed. Okay, so it's fully replaced by a different type of cell. And then neoplasia, this is going to be a new type of growth or a tumor. Okay, so that is kind of your overarching big picture, all of our types of cellular adaptation. And we are going to go through these again now one by one. Okay, so first we have atrophy. What's atrophy? A decrease in the cellular size. Okay, so you have a shrinkage in your cell size. If this occurs in enough cells of a specific organ, the organ itself will actually become smaller. Okay, so most commonly this is going to occur in skeletal muscles. Okay, so if you have been working out for a really long time and then all of a sudden you stop, everything's gonna shrink, okay? That would be atrophy. So skeletal muscle, heart muscle, the brain, and secondary sex organs. Those are gonna be the major places that this occurs, okay? Now this can be either pathologic or physiologic, okay? What does pathologic mean?
Disease.
Exactly. So this means pathologic, meaning that it is associated with an actual disease. Okay? Versus physiologic means this is more of a normal occurrence. It's not necessarily associated with a disease process. Okay? So if we're considering pathologic atrophy, so we know it's associated with a disease. Okay? That can be related to many different causes, okay? So it could be things like decreases in pressure, in workload, in blood supply, in general usage, like we said at the beginning, working out and not working out, so any type of disuse. It could be related to hormones, nutrition, or nervous stimulation. So it could be a result of many different potential things. This is very common to see, especially in hospital situations where somebody's bedridden, okay, where they're not using everything that they were using before and all of their organs are going to atrophy, okay? Let's see, if we are thinking about physiologic atrophy, so what does physiologic mean?
Occurs during the childhood.
Not necessarily, but more of a normal occurrence. So just not associated with the disease process, okay? So physiologic atrophy, it could happen in early development, so as a child is developing, that could be a natural thing, okay? But regardless of whether this is something that is occurring physiologically or pathologically, these cells that are going through atrophy will still show the same type of change, okay? It just doesn't tell you the reason why it's happening. Does that make sense? Okay, so we also have cellular hypertrophy. So what is hypertrophy? There's an increase in your cellular size, okay? So again, if enough cells in the same organ all hypertrophy, then you are going to have an enlarged organ, okay? Now, just like atrophy, this can be either physiologic or it could be pathologic, okay? So it could result from an increase in functional demand, okay? Now we started working out again. Our muscles are getting bigger, okay? That would be hypertrophy, okay? Or from hormonal stimulation, okay? The big physiologic ones that you're gonna see with this is an enlarged heart, if you've heard that term before, okay? So the heart is having to work harder, so it actually hypertrophies, okay? Or a kidney, same thing happens with the kidney a lot. Let's see. Okay, next we have dysplasia. Okay, so dysplasia, this is going to be the abnormal development and maturation of cells. Okay, so these cells are going to be abnormal in size, shape, or relationship to other cells. Okay, this could result from chronic inflammation or irritation, and dysplasia can actually progress and cause the formation of a tumor. Okay, so it could start here and then turn into a neoplasia. Okay, where this is the beginning phase and then it actually turns into a tumor. Okay, so a common example of this that you'll hear about is, or a common site of dysplasia, is the epithelium that covers the cervix and the uterus. Okay, so if you think about it, you know, women from a young age, we're getting pap smears. Okay, this is what they're looking for. This is the type of cell that they're looking for to understand if this is going to or could potentially develop into cervical cancer. Okay, so again, it's starting as this dysplasia, this abnormal cell type, and then progressing into cervical cancer, okay, or your neoplasia. Okay, so that's a good example there. All right, we also have cellular hyperplasia. What was this?
Increase in the number of cells.
An increase in the number of cells, okay? So this is often due to an increased rate of cellular division, okay? Typically, this is gonna happen in response to injury, okay? So if an injury has been severe or if it's been very prolonged, and caused cellular death, okay? So when this happens, the growth factors go in, they stimulate the remaining cells to synthesize, so creating new cell components and eventually divide with the goal of creating new cells, okay? So often, because of this, you will typically see hyperplasia and hypertrophy occurring at the same time, okay? So a lot of times, they will occur together, okay? But this also means that hyperplasia cannot occur in non-dividing cells, okay? So non-dividing cells are gonna be things like your myocardial fibers, okay? So in your myocardial fibers, you can have hypertrophy, but you cannot have hyperplasia. Okay. Again, this could be either physiologic or it could be pathologic. Okay, so if you think about compensatory hyperplasia, for example, okay? This is going to allow certain organs to regenerate, okay? So if you think about something like the liver is capable of regenerating, and this is why. Okay, so you have that compensatory hyperplasia that allows that to occur. There's also hormonal hyperplasia, okay? This is going to occur in more things like estrogen-dependent organs, okay, like your breast or uterus. Okay, very common in those. Okay, for pathologic hyperplasia, okay, this is going to be your abnormal proliferation, okay, so abnormal increase in number of cells. Okay, so these are gonna be things that are not due to hormonal stimulation or growth factor stimulation. Okay, so your most common example here for pathologic hyperplasia is going to be hyperplasia of the endometrium. Okay, so where you get an imbalance between estrogen and progesterone secretion. Okay, so you're going to get an over-secretion of estrogen. Okay. So we also have atypical hyperplasia, which is your dysplasia, which we've already talked about. Okay, so again, dysplasia, that's going to be more in your abnormal size, shape, and relationship. Okay, so this specifically, your atypical hyperplasia, is going to be an increased number of cells that result in an enlarged tissue mass. Okay, these types of dysplastic changes are usually found very close to cancerous cells. Okay, again, your most common example here is going to be related to breast cancer development. Okay, so overall here, your diagnosis of hyperplasia is going to be different depending on which organs are involved. Okay, but in general, you're going to have to do some type of needle biopsy in order to truly assess the cells. Okay, lastly here we have metaplasia. Okay, so this is going to be the reversible replacement of a single mature cell type by another cell type. Okay, so one cell type is replacing another cell type. Okay, and this is believed to occur due to what's called stem cell reprogramming. Okay, so basically you have prolonged exposure to some type of inducing stimulus, and then that's going to result in your potential dysplasia. It could result in metaplasia, where you have a replacement of your actual stem cells, and all of this could potentially lead to cancerous transformation. Okay. All right, so I know that was a lot of words. Do you agree? Not agree?
Yes.
We feel okay? You know all this already? Okay, we're not
Do you
joking.
think that
We'll get there.
a sunburn could be any of this?
A
Because-
sunburn,
Yeah, because a cell change as a
and it would be replaced.
Yes,
Yep.
but which one could be maybe?
So you would have, it would actually be like a cell injury turned into cell death, because then you're gonna get the shedding of the cells, and it's going to be replaced by the new cells.
Okay.
So it would be a full replacement. Okay. All right, so what we're gonna do now, again, since I know that was very wordy, we're gonna make it more hands-on, okay? A lot of physical therapists are kinesthetic learners, so I really try to incorporate different types of activity to stimulate learning in different ways to try to make sure we reinforce the material, okay? So does everybody have a piece of paper? Okay, so pull out a piece of paper.
That's what I think we're talking about.
That's what I'm saying, you're gonna get it under your nail.
It's gonna be even harder to
All right, so you each have a little container of Play-Doh, all right? You are going to take your Play-Doh out, and you are going to use your piece of paper to write out the names of your different types of cellular adaptations and what they are. So just a couple words to explain what they are, and then you're going to use your Play-Doh to physically create those different types of cells. Does that make sense?
Yes.
Okay, so then once you do that, I want you to take a picture of it so you can see, you know, when you go back to study, what it actually looks like for these different types of cells.
Yeah, I was like, is this enough? And then some tiny cells. Ah, I got it on my paper.
Smush them like smush them. Because I used my pen and I just smushed them.
What if we add like some water to it? Isn't that a thing? Would that make it worse? No.
It makes
It
it
makes
right.
a real bad idea.
Yeah.
Yeah.
The dye will come off.
Never mind. Oh, I got it. You might be able to add cornstarch.
Wait, you
Corn,
don't
yeah.
stick it.
We're just not gonna do that. Where they get the theory.
And the big old cells.
Beginning to see who the creative ones are in the classroom.
I have enough.
Regular cells. So it's like-
I feel like I'm gonna run out. Can I play with this the rest of the class? It's kind of big. I have pink under my nails now.
use this time, lecture finished, take a break if you need a break, go to the bathroom, get some water. Okay. Stand up.
That's all that matters.
Yeah, I'm genuinely enjoying this. Yeah, this is how you prevent burnout on the first one. Hey. Yeah, I'm here for it.
Little vacation.
Yeah. We all over winter break come back with episodes. It's nice. Exactly. True.
I'm sure they'll let you listen to the lectures. You can't hurt yourself with those. No headphones. Yeah, switch it on. The walls on here are self-discipline.
Oh my gosh.
You run that fighter? I'm surprised at how much I have left. I'm not gonna lie. I have a big chunk left. I'm kind of surprised.
She's beautiful.
That's beautiful.
She's huge. Wow.
She's beautiful. I promise I'll
Well, I thought about that when I was creating this. I was like, I'm gonna lose him after this.
Yeah.
I'm gonna be playing with Play-Doh the whole time.
promise all this. Therapeutic. I'll keep my hands to myself and listen. I have one too. Wait, I was gonna say, where's mine? Oh wait, mine might be cooler than yours. Mine might be.
Okay.
It has fur on it too, but oh yeah.
You're like, no problem, I'm a pro. I drink my own stress ball.
Right?
Oh, that's nice.
It's a nice one. I have two of them that are like that. I have a whole drawer full of sensory toys at my house.
I'm a big pro.
I work with special needs kids. I have to. I would feel this one though. It's like hard, but like
I like that. Like it makes you actually like
work for it. Yeah. It's a nice one. It's even just like you're pressing it.
I think more people probably could use fidget toys.
Oh yeah.
That's not falling out. Okay.
Yeah. She's at her back. I'm gonna make so many tiny little ones. Hold on. This will be great. His are very structured. His go upward too. Oh, he's building. Yeah, he's building his upward. Oh, Kat's got hers go up too. Mine are 2D. Play-Doh? Yeah. It's like, no, you didn't. I have, what's it called? The thinking putty? I have some of those at home. I have like, it's called like thinking putty, I think it's called, yeah.
got slime that smells like cookies.
I have slime that smells like hot candy.
It's got
Cloud
little
slime?
cookies.
There you go.
Okay, versus you can have an increased number of cells, that's not necessarily.
Oh, I did mine like little square ones, and then I did like little cells. Pollinators.
You destroyed your masterpiece.
I did. I took a picture of it there.
Alright, there you go. Yeah. Uh-oh. No paper. It's beautiful. What'd you make?
There's a lady on TikTok that makes dense bean salads.
You made.
I've tried a couple of hers, but she has one that's
You told me about your bean salads. You wanna know what I made yesterday? I made pumpkin chocolate chip cookies.
What are you really trying to ask?
I might make something for the cause, like pumpkin something.
Yeah,
At some point.
my kids are all about pumpkin muffins.
Shelby, you like make it doesn't have to be heated up.
Yeah.
Are you serious? I'm so proud of you guys. That's awesome. That's okay. You have a better base.
Y'all, look at my beautiful neoplasia.
That's awesome.
She gorgeous. Will I remember any of those? No.
I know it just makes me want to like do paper mache.
Yeah, I don't know.
Dude, I'm one of the kids who like, we're gonna do a project today, we're gonna help mom study.
Right?
Yeah, it just falls out.
Do it. Yeah.
Like, creates
Yeah, look at mine.
growth.
Mine looks like an avalanche.
It does.
Yeah. For sure.
I feel like your photos multiplying over there.
I don't know how I have so much.
Yours looks better than mine did.
It's not a comparison.
Mine had like little crystal things. Yeah, like it's dry. Yeah.
Like, oh.
You want to switch them all?
Oh, where'd you get this from?
CVS.
Is
mine.
is this like a stress thing?
Yeah. But it feels nice.
Yes, it does.
Yeah, it does.
Oh, if you, well, I don't know how much you can move it if you put it in the freezer or something.
It's a little fuzzy, so it's in my backpack.
It's gonna be so good, but I don't know if we're gonna have it done by this week.
What?
I forgot how it's recording and I forgot to pause it. That's what
I did that too.
You think that was helpful? Okay, so everything we talked about to this point was your cellular adaptation. Okay, now we're moving on to cellular injuries. So again, if the cell's initial adaptation is not sufficient, depending on the situation, that's when you're going to get a cellular injury. Okay, so now a cell injury is going to occur when a cell is unable to maintain its homeostasis due to a harmful stimuli, okay, whatever that may be, okay? So this is what is going to cause most diseases, all right? That's where this is gonna come into play. So now a cell injury, technically that can still be reversible or irreversible, just depending on the extent of damage that it's going through, okay? So it could recover or it could die, okay? So there are several different causes for these cellular injuries, and that's this section. That's what we're gonna go through next, okay? So we have to consider the different types of stimuli that's causing the injury, also the severity of it, okay, and then the duration. So those are gonna be your three main categories that you have to think about when we're talking about cellular injuries, okay? In addition, you're gonna have to think about the type, the state, and adaptive process of the cell itself, and that will all work together to determine the extent of the cellular injury, okay? So at this point, you know, just in science in general, it's not very well understood when that cellular death is no longer preventable, okay? So for us, the most important thing is just really to understand the mechanisms of cellular injury, not necessarily the prevention component of it, okay? So these are your big four categories for your I don't know what I just said, cellular injury mechanisms, okay? So number one, we have ATP depletion, okay? So here, there's a loss of ATP resulting in a loss of ATP synthesis, okay? Number two, we have oxygen and oxygen-deprived free radicals. So basically, a loss of oxygen is going to cause progression of cell injury in terms of ischemia. Bless you. Okay. Number three is going to be intracellular calcium and loss of calcium steady state. Okay. So changes in your intracellular calcium can damage membranes as well as cells. Okay. And then lastly, we have defects in membrane permeability, which can also cause cell injury. Okay, so those are your overarching mechanisms, and these are the actual forms of injury that can cause them. Okay, so several different forms of cellular injury. This is going to include hypoxic injuries, free radicals, chemical injury, physical injury, infectious agents, nutritional factors, genetic factors, and immunity, okay, or immunological reactions. All of these are going to work to play a role in the development of cellular injuries, okay? So we're going to talk most in depth on the first column here, and then, just briefly on the rest of them. So starting first with your hypoxic injuries, okay? So hypoxia is basically a lack of sufficient oxygen to the tissues, okay? This is going to be the most common cause of cellular injury. Okay, little asterisk there. Now, there are several different causes of hypoxia, okay? They include loss of hemoglobin, okay, or hemoglobin function, a decreased amount of oxygen in the air, okay? Any disease of your respiratory or cardiovascular systems, decreased production of red blood cells, okay, or any poisoning of the oxidative enzymes inside the cells. Okay, so most commonly, all of this hypoxia is going to be caused by ischemia. Okay, ischemia meaning reduced blood supply, basically. Okay. So when we talk about ischemia, the most common form of this that you guys will see is either narrowing or complete blockages of arteries. Okay. This could occur acutely, so that would be called acute anoxia, okay, or gradually, which is going to be less serious because it's going to be more progressive hypoxia. Okay. So an example here would be an acute coronary artery obstruction. That's going to be your best example. That's probably going to be the most common thing that you'll see in regard to your hypoxic injuries. Okay, that can cause myocardiac cell death, okay, or myocardial infarction, which is what? A heart attack. Okay, and that can occur within just a few minutes if your blood flow is not restored. Okay. Next, we have free radicals. Okay. So free radicals are continuously formed by the body, and they are really an important part of the body's metabolism, okay? But they can either have positive or negative effects. Okay, you probably learned about this in like chemistry or organic chemistry, something like that at some point, okay? So basically, as the body uses oxygen and food in order to produce energy, your free radicals are created as byproducts, okay? These are going to be unpaired and reactive electrons, okay? Usually those bind to oxygen for stabilization, okay? That's what's supposed to happen, okay? And then your oxygen will bind to hydrogen for additional stabilization, okay? So this series of reactions comes from your normal cellular metabolism, and then it can also cause oxygen toxicity. Okay, so when we're considering this toxicity, or oxygen toxicity, that is often related to the cause of neuronal degeneration. Okay, so specifically within the substantia nigra in the brain. And that's something we'll talk more about when you guys get to neuro rehab next summer. Okay, so again, a lot of this is just helping to form the foundation. But again, this can be a normal byproduct. It can also become pathologic when there's too much of that oxygen toxicity. Okay. When it does get to the point where it's affecting the brain as a result of all of this is going to lead to things like dopamine loss, reduced control over movements because of the area of the brain that it is affecting, okay, or producing abnormal body movements, okay. You're gonna see things like this in conditions specific like Parkinson's, okay, so it's affecting that type of area in the brain, okay. We also have chemical injuries. Okay, so first we have direct toxicity. This is going to occur when a chemical combines with a cell's membrane or organelles. Okay, it can also occur as a result of the formation of reactive free radicals, okay, just like we were talking about, and lipid peroxidation. Okay, where the free radicals steal electrons from the lipids, which will result in cellular damage. Physical injury. We'll probably see a lot of this in our field, okay? This is gonna be our biggest category in regard to all of these different types. So, in the US, they have it broken down into unintentional and intentional injuries. So overall, physical injuries are gonna cause 148,000 deaths in the US per year, okay? Unintentional injuries are the leading cause of death for individuals between 1 and 34 years old. Okay, so your classifications here for physical injuries include blunt or sharp force injuries, contusions, abrasions, lacerations, fractures, and asphyxial injuries. Okay, so we're gonna kind of break down these each a little bit further to make sure you guys are comfortable with the terminology. Okay, so starting first with contusions. Do you know what a contusion is? A bruise. Okay, don't make it more complicated than that. Just a bruise, okay? So there is no, underlying damage here. This is fairly superficial. It's the type of trauma. It's going to crush your initial soft tissue and rupture your blood vessels, but it doesn't break the skin. Okay, so there's no breaking the skin with a bruise. Okay. We also have a hematoma here, which is going to be a collection of the blood in the soft tissues or in enclosed space. Okay, so the important types that you need to know here are subdural hematomas and epidural hematomas. Your subdural hematoma is going to be that collection of blood under the dura mater and the brain surface. Okay, so this could be due to blows to the head, falls, any type of rapid acceleration or deceleration of the head. Okay. This is going to be the more emergent of the two, okay? So if somebody has this, they need to be hospitalized immediately, okay? It's going to likely require more an emergency surgery, okay? Versus your epidural hematoma, this is gonna be, it's still a collection of blood, but we're just in different layers. So this is going to be between the inner surface of the skull and the dura, okay? Usually that type is going to be more related to a torn artery, secondary to a skull fracture. All right, next we have abrasions. So abrasion, this is gonna be more a scrape, okay? So you have a removal of the superficial skin layer, okay? Due to friction between some other object and the actual skin, okay? So usually, initially, these are going to be a little bit more pale, moist, have a yellowish appearance that will then darken or brown as the injury starts to dry. okay? It's typical to see an oozing substance for the first 1 to 2 days until it completely covers by a scab, okay? And then eventually, the scab will flake off to reveal the new underlying skin tissue. Okay, we also have lacerations. Okay, these are gonna be actual tears or rips in the skin, okay? So these are gonna be more jagged, more irregular. They might have abraded edges, okay? So not typically something that's just a clean cut. The depth can also be irregular, okay? So depending on what happened, it can be a little bit more superficial, it can be a little bit more deep. There's not a defining structure to what that necessarily is. Okay, our last type here is asphyxial injuries. Okay, so this is going to occur when the cells either fail to receive oxygen or fail to use oxygen. Okay, so here you're just getting oxygen deprivation for whatever reason. Okay, that's also called anoxia, or partial deprivation, which is called hypoxia. Okay, so those are the difference in those two terms. So your examples here are going to be things like suffocation, strangulation, chemical asphyxiation, or drowning. So for suffocation, okay, this is basically when oxygen fails to reach the blood. Right? That could be caused by a lack of environmental oxygen or some type of blockage of the external airway. Okay? If your oxygen levels drop below 5%, death can occur in just a few minutes. Strangulation, okay, this is going to be compression and closure of the air passages or blood vessels due to an external pressure on the neck, okay? Most strangulation deaths are going to occur actually from alteration of the cerebral blood flow and not just a total overall loss of blood flow, okay? Or airflow, I'm sorry. So basically, complete blockage of your carotid arteries can cause unconsciousness in about 10 to 15 seconds. So this can occur very rapidly. Okay. We also have chemical asphyxiants. Okay, so again, these can either block the appropriate utilization of oxygen or prevent oxygen delivery to the tissues. Okay, so your most common chemical asphyxiant is going to be carbon monoxide. Okay, that carbon monoxide is going to prevent oxygen from binding with hemoglobin. Okay, and then lastly here we have drowning. So with that, we have cerebral hypoxia, especially after breathing in fluid, and that's again going to lead to unconsciousness in just a few minutes. Okay, so at this point, we've talked about cellular adaptations, we've talked about the different types of cellular injuries, and now we have the actual cell death here, okay? Cellular death is eventually going to lead to necrosis, which is cellular dissolution, okay? So those two terms are synonymous. So this results after localized cell death and autolysis, which is cellular self-digestion. So we have 5 major types of necrosis, okay? So they're all listed here for you guys. Your first one is coagulative necrosis. So this is going to result from hypoxia, okay? So whenever there is severe ischemia or hypoxia, specifically due to chemical injury. Okay, number 2 is liquefactive necrosis. So this is going to occur whenever there is ischemic injury to the neurons and glial cells. Okay, so specifically in the brain. This is often caused by bacterial infections. Number 3 is fat necrosis. Okay, this usually results from lipase enzymes that break down triglycerides. And then number 5, gangrenous tissue, or basically gangrene, okay? This is going to result from severe hypoxic injury. That's due to arteriosclerosis of your major arteries. Okay, so those are your 5 different types of necrosis. Okay. We also have at the bottom here what's called apoptosis. So that is going to be a normal occurrence that's defined as programmed cell death. Okay, so here the cells basically digest themselves via enzymatic action. Okay, so this is self-destruction and allows them to disintegrate into different fragments. Okay, so all of the cells will automatically go through this in cell development. And it's a problem, or it can be a problem, when the cell development is abnormal for whatever reason. They didn't, form properly. If cell numbers are excessive, then they could undergo this, or the cells are injured and aged. Okay, so those are some different reasons that they might automatically go through this programmed cell death. Okay, so cellular lysis. This is going to be when the actual cell dies and the nucleus disintegrates. Okay, so lysis, that means dissolution. Okay, so this lysis releases enzymes into the tissue, and then that can cause inflammation. Okay, so if there's a large amount of dead cells, that can cause the enzymes and the inflammation to then be excessive, okay, or extensive, which in turn could potentially kill more cells. Okay, so a lot of times these dead cells will release enzymes into the bloodstream, and then that can help, physicians to identify what type of cell is actually being damaged. So a lot of times when you're getting blood work, these are things that could be assessed. Okay, so going back to our myocardial infarction, an infarction basically just describes an area of dead cells that were harmed due to a lack of oxygen. Okay, so you could have, functional loss that may be significant if there's a large amount of dead cells in one area. Okay, so the biggest example for us, again, is going to be your myocardial infarction. A large area of cells in the heart have died, so the heart fails. Okay, and then like we said earlier, your heart cells, they do not reproduce. Okay, so they're not going through that typical division process to then regenerate. So that's when it becomes a problem with the heart. Okay. In general, your different types of cells will die at different rates. Okay, so it's not like this structured program, at age 15, we just do a cleanse and we start it. So every organ system is going to be a little bit different. Okay. In terms of your actual infarctions, if you look at the comparison between the brain and the heart, for example, brain cells with a lack of oxygen will die in about 4 to 5 minutes, versus the heart, it can survive for up to 30 minutes. So everything kind of has a little bit different of a qualification there. Okay, now when it comes to aging, injury can result again for a lot of different reasons. So it could be exposure from UV light exposure, mechanical injuries, metabolic reactions, all different types of things. Okay, but overall, the relationship between your aging and disease and yourself, it's not all, a picture perfect, clear understanding of what that actually looks like. Okay, we do know that you can expect certain levels of atrophy as you age. Okay, that's a normal expectation. But the actual change from what's normal to what's pathologic, when the injury state, when the cell death is going to occur, that is not necessarily clear. Okay, but it is speculated that there is a result of an accumulation of the trauma that's sustained over a person's lifetime that leads to your cellular injury and cellular death as you're aging. Okay. It could also be the result of your self-destructive process that we already talked about, and also if there's any genetic predetermination. Okay, so if there is some type of predetermined genetic schedule where your cells are gonna go through this programmed cell death, that's also a possibility. But again, at this point in science, it's not clearly understood, okay? So overall, big breakdown, big picture of this portion of the presentation. Your cells can adapt, your cells can become injured, your cells can die. So make sure you understand the different mechanisms behind each of those portions, okay? And know that a lot of this can be reversible if it is caught early enough, okay? All right, let's take back out our sheets from earlier where you answered all your questions. I want you to find somebody in this room. If you've either not talked to here, you guys are killing it, doing awesome. So this is going to be, we're kind of shifting gears, changing directions a little bit. This is going to be more about your genetic and your congenital disorders, okay? So think when we talk about these things like birth defects, okay? These can develop either prenatally or during the birthing process, okay? So when we talk about congenital, that specifically does not either indicate or exclude genetic disorders, okay, which are hereditarily linked, okay? Genetic disorders can occur from chromosomal disorders, multifactorial disorders, or single gene disorders. And those are the things that we're going to break down through this presentation, okay? So just starting first with a little reminder of biology, okay? So how many pairs of chromosomes does the human body have, or a human cell have? 23. Seems a little hesitant, but yes, 23. Okay, and all of your genetic information is stored within these chromosomes. Okay, 22 of them are called autosomes. Okay, so those are going to be numbered and by their size and the shape of the karyotype. Okay, and then what's your final pair?
Sex chromosomes.
Sex chromosomes. Okay, so XY for males and then XX for females. Okay, so just in case you haven't thought about that stuff in a minute. Okay, now each sperm and each ovum receive the 23 chromosomes during meiosis. Okay, so once the ovum is fertilized by the sperm, the zygote that forms has a combined total of 46 chromosomes. Okay, so it's 23 pairs. Okay, so with that, obviously you have many different possible combinations of the genes. Okay, now what makes it, and this is basically what makes it unique for your DNA to each individual. Okay, so your genes are composed of the DNA strands, and then those are matched for certain functions. Okay, and that's your alleles. A genotype is going to describe the same chromosome and genetic content that is contained in each person's body. Okay? And then now know that not all of your genes are going to be active in every cell. Okay, that's why we have the term gene expression. Okay, so what is actually expressed through the genes. Okay, so you have a communication link with your DNA, which is called your RNA. Okay, RNA communicates with DNA when protein synthesis is occurring. Okay, and that's what helps to control the cellular activities. So when the cells are undergoing mitosis, or your cellular division, during embryonic and fetal development, the chromosomes will replicate. Okay? Each daughter cell receives identical DNA to the DNA that exists in the parent cell. We also have mutations, which is an alteration in the genetic material that could be caused by things like radiation or exposure to harmful drugs, or they can also just occur spontaneously. There is current research that is known as gene mapping that is going on, and that's helping to progress as scientists identify the roles of each human gene. Okay, so there's what is called the International Human Genome Project, and they are attempting to identify and map every gene on every human chromosome. Okay, so there's been millions of pairings that have already been listed. but there's still more to be done here, so this is still just a work in process. So when a specific gene is identified in terms of relation to pathologic condition, that makes it a little bit easier to develop a blood test that could screen for that particular gene. Okay, so like we said at the beginning of this portion, we know that congenital disorders that are present at birth are related to your congenital defects. Okay, so these are going to include your genetic or inherited disorders, as well as any developmental disorders. Okay, genes control every physical characteristic that we display. When a gene is altered, that's when you're going to get the development of a disease. Okay, so your patterns of inherited genes include dominant and recessive traits. Okay, and those are going to be predicted using Punnett squares. So again, I'm sure you guys did those, might have been a long time ago, but basic biology, Punnett squares, that is going to help to show the expression of your genes. Okay, so with this, you have an example there. Your capital letters are going to be the dominant genes, and then the lowercase letters are going to be the recessive genes. Okay, so for single gene disorders, these are going to occur in approximately 1 out of every 200 births. Okay, so these are going to be classified by their inheritance pattern. So you have your dominant, recessive, or X-linked recessive. So those are the things that we're going to talk a little bit more specifically through. So that leads us to genetic disorders. So this list of 5 types, these are your genetic disorder types. So we have autosomal dominant disorders, autosomal recessive, X-linked, chromosomal, and multifactorial. Okay, so one by one, we're going to go through these. So starting first with your autosomal dominant disorders. Okay, so some of these actually do not become expressed until later in life. So even midlife, you could start to display characteristics of these. So here you have a defect that is present in one allele that produces clinical expression of the disease. Okay, so here an affected parent will have a 50% chance of passing on that gene to their child. Okay, so here no carriers exist. Okay, so unaffected parents do not transmit the disorder. It would have to be specifically through an affected parent. Affected parent can pass that on to their child. Okay, so the 2 big types of autosomal dominant disorders that we're going to talk about that you're going to see are Huntington's disease and Marfan syndrome. All right, so Huntington's disease, again, this is going to be an autosomal dominant disorder. Okay, now there are screening tests available for this at this point. Okay, but it's going to cause a degeneration of the brain that typically develops in about the mid-30s. Okay, so again, this is not something that you typically see, you know, in younger kids or at birth. It will be a little bit later in life where they're going to start the expression of these genes. Okay, this is going to be characterized by progressive mental deterioration. Okay, you'll likely see abnormal writhing movements or abnormal jerky movements just in their everyday lives. And this is typically very slowly progressive and will usually lead to death in about 15 to 20 years after it's been diagnosed. Okay. For this, more specifically, you're going to have atrophy. What is atrophy?
Decrease the size of the cells.
Decreasing of the size of the cells. Atrophy of the neurons in the basal ganglia. Basal ganglia is in the brain. Okay? You guys remember, or if you've had it before, the basal ganglia, what kind of things are you going to see if that's affected? Don't know that yet? Okay, so basal ganglia, that is like your center for coordination. Okay, so if your cells in the basal ganglia atrophy, you're going to have a lot of coordination difficulties, okay, specifically in your movement expression. So that's why they're getting more of those jerky, writhing type movements. Okay. The cerebral cortex will also be affected here, and eventually that's going to lead to dementia. Okay. Again, this is a progressive condition, so this is not something that can be stopped, but it can be kind of controlled with appropriate medication. Okay, we also have Marfan syndrome. So this is going to be more of a connective tissue disorder. Okay, so we know connective tissue is going to be giving size, shape, structure to body tissue and kind of holding everything in place. So with this condition, they're typically going to have a lot of skeletal deformities. Okay, they'll have longer than normal limbs, arms, hands. You can see in that picture really long hands typically, or long fingers. They'll also typically have cardiovascular abnormalities, eye problems, hypermobility in the joints. Do you know what hypermobility is?
Too much mobility.
Too much mobility, so excessive movement in their joints. Okay, so overall, these individuals are usually kind of lengthy, tall. The body will appear very long and very thin. Okay, the most dangerous effects of this is going to be to the cardiovascular system. So they usually have mitral valve prolapse, weakness of the aorta and the other arteries in the heart. Okay. Again, this condition cannot be cured. Okay. It is recommended to avoid very strenuous activity due to the stress on the heart. Low to moderate activity is okay, but again, this is not something that is going to go away or be cured in any way. Okay, next we have autosomal recessive disorders. Okay, so with this, both parents are going to pass on a defective gene. Okay, so this is going to include a couple highlight conditions that we're going to talk through here: albinism, fetal ketonuria, so it's PKU, and Tay-Sachs disease. So again, for these diseases to develop, both parents have to pass on the defective gene. Okay. So a child who is heterozygous will have received one normal gene and one defective gene. Okay, so they could be a carrier for this. Okay, versus a homologous child, okay, where they would have defective genes coming from both parents, where they would eventually display the characteristics of this condition. Okay, so here we have albinism. Okay, so this is a very common genetic defect. So here, the two recessive genes are inherited. Okay, and this is going to result in a metabolic pathway deficiency related to the production of melanin. Okay, so we know that the brown pigment is responsible for the coloration of the eyes, the hair, the skin, and you're going to have a deficiency in that. So individuals who have albinism are going to have reduced or not have any at all in terms of their levels of melanin. Okay, so here these individuals, their skin is going to appear very pale. Their hair will be white. The iris of their eyes is going to be pink. We also have cystic fibrosis. Okay, so again, this is an autosomal recessive disorder. Usually these individuals are going to have a shortened lifespan. Okay, so often this is going to be the cause of early death in these individuals. This condition basically changes how the sweat glands in the skin function. It alters, most importantly, the effects of the respiratory system's mucus glands, okay, as well as your pancreatic ducts. So when the sweat glands are defective, there's going to be excessive salt that is released from the body, okay? The most serious symptoms, again, is going to affect more the lungs and the pancreas. So for the pancreas, the pancreatic digestive enzymes don't normally drain into the small intestine because of the clogging of the ducts. Okay, so the ducts are gonna get clogged and you're not gonna get that appropriate enzymatic drain. The digestion is going to be impaired, okay? So that means you're gonna get a buildup of those enzymes that will result in the formation of cysts, okay? So with that, the pancreas basically slowly starts to degenerate, okay? And fibrous tissue will begin replacing the glandular tissue, okay? For the lungs, they have a severe excretion of mucus, okay? So have you guys ever seen this condition firsthand? Okay, so these individuals have a lot of trouble with breathing, and you often have to, like, whether it's the parents of the child, whatever it may be, whoever their assistant person is, will often have to kind of beat the mucus out of them. A really aggressive way of saying that. Sorry?
My cousin has a vibrating chest.
Yeah.
I'd like it to
Yeah.
look him up. And like,
That's perfect. So something just to kind of loosen all of the secretions in the lungs, get the mucus moving a little bit better, but it can be pretty intense as well. Okay, next we have PKU. Okay, so this is going to be a rare metabolic disorder. Okay, and it's going to be caused by a deficiency of liver enzymes. Okay, so here you're going to get toxic levels of phenylalanine, and that's going to accumulate, and they're going to end up with a lot of mental disorders, delayed speech, microcephaly, other symptoms that really will display as neurologic type impairments. Okay, so this is something that typically develops very gradually, and oftentimes kind of the cognitive impairment is going to be the first sign of it, and that is going to be present before this condition is really diagnosed. Okay, but in today's day and age, this is something that's typically immediately screened in all newborns. Okay, now if somebody does have this, if this is found in that screening process, these infants are going to be put on significant dietary restrictions, basically immediately. Okay, that's going to be started neonatally between days 7 and 10 after birth. Okay, and that alone, those dietary changes will help to prevent further brain disease or damage. Okay, we also have Tay-Sachs disease. So this is going to occur when there is a failure to break down components of cell membranes. Okay, so that is known as gangliosides. These gangliosides will accumulate in the lysosomes of the brain, of the retina, and other organs. Okay, so over time, the neurons will get destroyed here, and that is going to affect the brain. So all of these different areas, your cerebellum, your basal ganglia, your brainstem, and then that will go down the spinal cord and affect the autonomic nervous system as well. So again, typically you're going to see this early in infants, where they might appear normal initially, but they are very quickly going to develop plasticity in their muscles, weakness, decreased attentiveness. So typically you'll see this between about 6 and 10 months, okay? And there's going to be a rapid deterioration, okay, in both mental and motor functions, okay? So unfortunately, there is no cure for this condition, and these children typically will die by the age of 5. Okay, so it's very serious and sad. Okay, next we have X-linked disorders. Okay, so X meaning that these are going to be carried by the female chromosomes. Okay, these are recessive. Okay, this is going to include your biggest one here. We don't have a slide on it. We'll talk about it in our pediatric section. But your biggest one is Duchenne muscular dystrophy. Okay, so you've heard of that before. So even though they're carried by the female, oftentimes these are going to be present in males. Okay, so the other ones that we'll talk about here are hemophilia A, and then von Willebrand's disease. So here, female carriers will have a 50% chance of producing a male child who is affected with these, or with an X-linked recessive disorder. And then they also have a 50% chance of relating this to a female child who would then be a carrier. So it's carried through females, but expressed in males. Okay. So starting first with hemophilia A, okay, this is going to be the most common inherited bleeding disorder. Again, this is mostly going to affect males. Okay. This is caused by a deficiency of factor VIII, which is essential for normal blood clotting. Okay, so here, when the disease is very severe, bleeding typically occurs in children just spontaneously, okay? And it could occur, several times a month. So you obviously know something is not right with these children. So it's very important that if somebody does have this, that they are educated to avoid contact sports, okay? Because that could very quickly lead to a severe bleeding episode. And then last one here, we have von Willebrand's disease. So again, this is, wait a minute. So this is going to be caused by a lack of dysfunction of the molecule called VWF. There are 3 different types of this condition, but we are not going to dive into that, okay? So don't worry about that part for now. Just know that this is also a bleeding disorder, where there is an excessive amount of mucosal and skin bleeding, especially after any trauma or any surgery. Okay, next we have chromosomal disorders. Okay, so these often will occur due to error during meiosis, where a DNA fragment are displaced or lost, something like that. Especially during the process of spindle formation, or that crossover effect that you see in DNA. Okay? So chromosomal disorders are going to be most common when the mother of the child is over 35 years old, okay? And that could result in chromosomal translocation or deletion or an abnormal amount of chromosomes. Okay, so several different potential methods of achieving the chromosomal disorder. Okay, so the most common inherited chromosomal disorder is going to be Down syndrome. Okay, so nearly all cases of Down syndrome are going to be caused by a cell division error, okay, which results in a triple copy of chromosome 21. Okay, this is also called trisomy 21. That's how you'll hear it referred to as. So 3 chromosomes, chromosome 21. So in most cases, an infant that has Down syndrome will ultimately have 47 chromosomes opposed to 46. Okay, so you have that one extra. In terms of your physical features for this population, they're going to have reduced body growth overall, smaller and more squared type appearance. They will have flatter than normal facial features, a smaller and depressed nose. They may have slanted eyes, malformed ears, fatty deposits at the back of the neck, more of a tendency for the mouth to sit in an open position. Oftentimes the tongue will also be larger and more protruding. And then hands will be kind of short, a little bit more stubby in features. They may have inwardly curled fingers, among many other symptoms, but that's kind of your big overall common picture for this population. Okay, they often have a lot of associated secondary conditions as well. So things like, Alzheimer's, dementia, slower motor skills, overall hypotonia, those things are all also associated with this population. Okay, next we have Turner syndrome. Okay, this is caused by absence of the X chromosome. Okay, so only one sex chromosome is present. Okay, and that's when you're going to get Turner syndrome. So here, in opposition to trisomy 21, overall the infant is only going to have 45 chromosomes. Okay, And again, this can cause many physical abnormalities, okay? If female, then they will likely lack ovaries, okay? So, again, you're gonna have more of a shortened stature, but they'll have normal body proportions, okay? They will likely have poor breast development, infertility, lymphedema, neck webbing. Their bone age may be, I don't know what the term is, like it doesn't age appropriately, so bone age kind of stays a little bit younger and does not go through its appropriate development. And again, this could cause other organ issues as well, so heart issues, lung issues, kidney issues. They will likely have poor motor skill development, attention deficit disorders, all kinds of things for this condition as well. Typically, this population will begin hormonal treatment at a very early age, okay? So usually estrogen will be used, especially around the normal age of puberty, to try to help promote some of that development that they're naturally gonna be lacking. Okay, last one here is gonna be Klinefelter syndrome, okay? So this only affects males, okay? And it is basically a testicular dysgenesis, where there's the presence of one or more extra X chromosomes, okay? So they're gonna have, or they're gonna present more with enlarged breast, less than normal body hair, likely small testes, and then likely infertility as well. Okay. All right, last category here is going to be our multifactorial disorders, okay? So this section includes, you know, a wide range of different pathologies and diagnoses. We're not gonna go through them all, but just kind of give you guys an idea of what this actually means. So specifically here and indicated in your book, this is going to be just more an association, okay? So an increased tendency for these types of conditions to develop with additional exposure to some other factors aside from genetics, okay? So basically your genetics are putting you at increased risk, or it's giving you a predisposing factor to development of some of these conditions, okay? So here is a big list of all of these things, okay? So some of the things that especially we'll talk about as you guys move forward: congenital hip dislocations, high blood pressure, high cholesterol, osteoporosis, schizophrenia, a lot of your psychological conditions, again, where you can have a predetermined genetic disposition to it, but that wouldn't necessarily manifest without some additional external factor associated with it. Okay, so a little bit on screening tests, and then we'll kind of wrap this up. So there's a lot of different diagnostic tests that you can be used to determine abnormalities, both prenatally and neonatally, okay? So especially if there is a known family history of some type of disease, testing is gonna be especially recommended in those cases, so you know what to expect through your pregnancy or your birth, okay? So, any parent who has previously given birth to a child that had some type of genetic disorder, they're going to recommend testing if you have multiple children after that, as well as any woman who is, again, over the age of 35. They're naturally going to be at increased risk for genetic conditions, so testing for those things is going to be really important at that time. Common screenings that can be done based on the disorders that we already talked about. There is specific screening tests for Tay-Sachs disease as well as sickle cell disease too. Okay. So for these different types of testing, diagnostic tools that can be utilized include ultrasound, blood test, amniocentesis. Those are some common things that you'll see at this point. DNA test as well, if we do know that there's a genetic component. However, there may not be conclusive results until about 16 to 18 weeks into pregnancy. Okay. Now, what we have on this slide here is this torch screening. So there are just routine prenatal screenings that any woman would receive especially those at high risk, okay? So these are signified by your acronym of TORCH. So that's going to include toxoplasmosis, which is basically an infectious disease caused by a protozoan. Okay. Other, that is going to be inclusive of hepatitis B, mumps, rubiola, gonorrhea, syphilis, varicella. All of those things will automatically be tested. Okay. R is going to be your rubella. So just getting your typical common routine vaccinations has nearly eliminated this, but this will still be tested for. C, cytomegalovirus, and then H, herpes, okay? So for herpes, typically neonatal infection is usually required during the actual birthing process. So as the baby passes through the birth canal, that can be transmitted from the mother to the baby, okay? So again, this is your typical prenatal screening that everybody would go through. We also have neonatal testing, okay? So this typically occurs within the first 48 hours after giving birth. And the baby is usually pricked on their heel to get a blood sample to go through these things, okay? So again, condition specific at this portion that they're looking for is going to be sickle cell anemia, congenital hyperplasia, toxoplasmosis, cystic fibrosis. We'll test their hearing, their sensation, all of those types of things. Okay. There's also gene testing. Okay, so we have gene testing, there's DNA testing, there's genetic engineering, and there's gene therapy. Okay, so when we talk about gene testing, this is going to be used to identify any type of genetic disorders, okay? Specifically in the embryos or in the newborn babies, okay? Let's see. We're not gonna dive too deep into this, but do understand, like, a lot of this, we know that there's going to be an ethical debate or an ethical dilemma, okay? When it comes to specific alteration of gene expression. Is that something that should be okay? Is it something that shouldn't be okay? So, at this point, you know, we're not gonna have a class argument, because I know a lot of you guys just met each other, but something to kind of be thinking on, reflecting on, you know, determining your own feelings about it, because that's something that I think as we progress in the next several years, that we're probably gonna be starting to see a little bit more of. Okay, so just know, at this point, there's gonna be a lot of controversy around it. Okay, specifically in regard to this slide, when you start talking about manipulating genes. Okay, so you can go in and change an actual DNA sequence, okay, in order to alter the gene expression. So gene manipulation is going to focus on removing a defective gene, okay, and replacing it with a normal gene, okay? Basically using it to manipulate and eliminate any genetic defects, okay? So you can alter the DNA and you can produce identical molecules or clones of that DNA. One thing that this also can be used to do is mass produce vaccinations, okay? So, you know, I think that's a pretty good utilization of it. That goes a little bit into a different direction compared to manipulating the genes in an embryo. Okay. But there is a lot of research going on here and a lot of promise in terms of finding cures for certain diseases that don't currently exist. So things like your cystic fibrosis, your Huntington's, polycystic kidney disease, things like that, this can also be used in order to find cures for those conditions as well. So it's interesting, but basically by introducing normal genes into living target cells, cell activity can be changed, it can be adapted, or missing genes could be replaced. So this is, you know, a whole different world. We're not really going to talk about it through the duration of the program or anything, but again, just something to expose you guys to start, you know, getting into things like that. Okay, so we made it through the material. Congratulations. Again, I know it was a lot. It's a lot of words. Okay, not the best, you know, first day introduction to the program, but you guys are fine. make sure that you review this, like, start today, okay? Because every week, it's just going to compile every day. Come tomorrow, we have a whole new set of information you're gonna have to learn. So each day, make sure you're reviewing the material from the day, and then come the weekend, review everything from the week, okay? All right, we have one more thing that we are gonna do. And let's see. Some of these actually have names and some of them don't. So while I'm passing these around, let's have you guys find a new person that you haven't talked to and just introduce yourself.